Welcome back to the PTCB Top 200 Drug Series. I'm Izzy, certified pharmacy technician with 9 years of pharmacy experience, 146 drugs covered. Today, episode 14, covering the drugs that transformed HIV into a manageable chronic condition. AZT, Biktarvy, Truvada, Navir, Tamiflu, Paxlovid. These are the drugs that treat HIV, herpes, influenza, and the COVID-19 coronavirus. For the PTCB, this is a suffix-heavy class. Learn the patterns to answer classification, safety, and interaction questions. The PTCB tests antivirals across medications, patient safety, order entry, and the federal requirements content domains. Medications covers suffix tricks and mechanisms. Patient safety focuses on genetic testing and critical renal dose adjustments. Order entry covers combination products and formulation differences. Federal requirements include specific REMS programs and drug status. 19 drugs, 4 classes, 1 booster, 1 genetic test, 1 48-hour window, 5 practice questions. Let's go. HIV treatment is built on 4 drug classes. First, NRTIs, nucleoside and nucleotide reverse transcriptase inhibitors. Look for vudine and fovir suffixes. These structural analogs cause chain termination to stop viral DNA replication. AZT proved HIV treatment works. All NRTIs require renal adjustment except Abacavir, which is primarily hepatically metabolized. Tenofovir DF, TDF, has renal and bone risks. Tenofovir AF, TAF, is newer with reduced toxicity. Abacavir requires HLA-B 701 testing before dispensing. A positive test is contraindicated because the reaction can be fatal. NNRTIs, non-nucleoside reverse transcriptase inhibitors, use the vir infix without navir or tegravir endings. Efavirenz causes vivid dreams and dizziness. Take it at bedtime on an empty stomach to minimize these effects. Nevirapine carries a black box warning for severe hepatotoxicity, particularly depending on the patient's CD4 count. Protease inhibitors use the navir suffix. They block enzyme cleavage, resulting in non-infectious, immature viral particles. Ritonavir is a potent CYP3A4 inhibitor used almost exclusively as a pharmacokinetic booster to increase antiviral efficacy. Protease inhibitors cause long-term metabolic side effects like lipodystrophy, hyperlipidemia, and insulin resistance in patients. Integrase strand transfer inhibitors, NNRTIs, use the tegravir suffix and are now the preferred first-line agents. Dolutegravir has pregnancy warnings. Biktarvy is in Biktarvy, the most prescribed HIV single-tablet regimen today. And Fuvertide is the only injectable antiviral. Maraviroc requires a tropism assay to check if the virus uses CCR5. Acyclovir and Valacyclovir treat herpes. Valacyclovir is a prodrug with higher oral bioavailability for less frequent dosing. Oseltamivir, or Tamiflu, must start within 48 hours. Take it with food to reduce common GI side effects. Paxlovid for COVID-19 must start within 5 days. It requires a massive drug interaction screen before every dispense. Vudine is Retrovir. Lamivudine is Epavir. Emtricitabine is Emtriva. Tenofovir DF is Viriad. Tenofovir AF is Vemlidy. Abacavir is Ziagan. Efavirenz is Sustiva. Nevirapine is Viramune. Ritonavir is Norvir. Darunavir is Prezista. Question 1. A prescription is received for Abacavir for a new HIV patient. The pharmacy technician notes that no HLA-B 5701 test result is available in the patient's profile. What is the most appropriate action? A. Dispense the Abacavir. The test can be ordered retroactively. B. Hold the prescription and notify the prescriber. Abacavir is contraindicated without a documented negative HLA-B 5701 test, because a positive result predicts a potentially fatal hypersensitivity reaction. The test must be performed and documented before the first dose is dispensed. C. Dispense the Abacavir, but counsel the patient to monitor for rash. The test is recommended, but not required. D. Substitute tenofovir without contacting the prescriber. all NRTIs are therapeutically interchangeable? The answer is B. HLA-B 5701 testing is not optional for Abacavir. It is a prerequisite for dispensing. A positive test means Abacavir is permanently contraindicated. The hypersensitivity reaction can be fatal on rechallenge. This is among the most tested patient safety domain questions in the antiviral section. Question 2. A pharmacy technician is reviewing a medication profile for a patient on Paxlovid. The patient's active medication list includes simvastatin 40 mg daily. Which CHLA-B 450 mediated interaction should the technician flag? A. Paxlovid is a CHLA-3A4 inducer and will reduce simvastatin levels. No clinical concern. B. The Ritonavir in Paxlovid is a potent CHLA-3A4 inhibitor. It significantly increases simvastatin serum levels, raising the risk of rhabdomyolysis. Simvastatin should be held during Paxlovid treatment. The prescriber must be notified before dispensing. C. Paxlovid only interacts with anticoagulants. Statins are safe. D. Simvastatin inhibits CYP3A4, which will reduce Paxlovid efficacy. The simvastatin dose should be doubled. The answer is B. Ritonavir is one of the most potent CYP3A4 inhibitors in clinical use. Simvastatin is a CYP3A4 substrate. The combination can produce simvastatin levels many times higher than normal, causing rhabdomyolysis. This is a medication safety and order entry domain question. The pharmacy technician must screen for CYP3A4 drug interactions before dispensing any ritonavir-containing medication. Question 3. A patient calls the pharmacy at 2 p.m. on a Tuesday. Her flu symptoms started Saturday morning, approximately 78 hours ago. She has a new prescription for Oseltamivir and asks if it is still worth taking. What is the evidence-based counseling response? AA. Oseltamivir is effective whenever it is started. The 48-hour window is a guideline, not a clinical requirement. B. She should start the medication immediately. The 48-hour window only applies to children. C. Oseltamivir is most effective when started within 48 hours of symptom onset. Her symptoms began approximately 78 hours ago. Clinical benefit beyond 48 hours is significantly reduced. She should discuss with her prescriber whether treatment is still indicated given the delay. D. Oseltamivir is not approved for influenza. She should ask for a different medication. The answer is C. The 48-hour window is the most tested counseling point for Oseltamivir. Technicians should know this window because it determines whether the prescription is clinically appropriate. Flagging a delayed start for pharmacist review is an order entry and patient safety function. Question 4. A pharmacy technician is entering a new prescription for Tenofovir disoproxyl fumarate 300 mg daily plus emtricitabine 200 mg daily. The patient has a medical history notable for chronic kidney disease stage 3 with an estimated GFR of 42 N-almine. What is the correct processing step? A. No dose adjustment is required. Tenofovir is hepatically metabolized. B. Tenofovir disoproxyl fumarate requires renal dose adjustment. At a GFR of 42 ml/min, the standard daily dosing of TDF is not appropriate. The technician must flag this for pharmacist review. The prescriber may need to adjust the dose or switch to tenofovir alafenamide, which has reduced renal toxicity at this level of renal function. C. Only emtricitabine requires renal dose adjustment. Tenofovir DF is safe at any GFR. D. Both drugs should be discontinued. NRTIs are contraindicated in CKD. The answer is B. TDF requires renal dose adjustment. Its nephrotoxicity and reduced clearance at lower GFRs make standard dosing inappropriate. The technician's role is to flag the discrepancy between the prescribed dose and the patient's renal function for pharmacist and prescriber review. The clinical alternative, switching to TAF, reflects the PTCB distinction between the two Tenofovir formulations. Question 5. A patient on Darunavir plus Ritonavir asks what the Ritonavir is for, since she knows Darunavir is her main HIV medicine. What is the correct explanation? A. Ritonavir is a second protease inhibitor that treats HIV independently of Darunavir. The combination ensures complete viral suppression. B. Ritonavir is included at a low dose as a pharmacokinetic booster. It is a potent CYP3A4 inhibitor that inhibits Darunavir's metabolism, increasing Darunavir serum levels. This allows Darunavir to be dosed once daily instead of multiple times daily and increases its antiviral efficacy. At the low boosting dose, Ritonavir does not contribute to antiviral activity. C. Ritonavir prevents the nausea that Darunavir causes. It is an antiemetic additive. D. Ritonavir prevents Darunavir resistance. It has no other clinical effect. The answer is B. The concept of Ritonavir boosting is one of the most tested antiretroviral pharmacology concepts on the PTCB. At low doses, Ritonavir functions as a CYP3A4 inhibitor. It increases the serum levels of the co-administered protease inhibitor, improving efficacy and allowing simpler dosing. It does not contribute antiviral activity at the boosting dose. This is a medications domain question. 165 drugs, 14 episodes. The top 200 series is complete. Subscribe and study hard.